dedicated and wonderful medical officer whom I visited some of his patients when I visit Sri Lanka. He's a medical officer working at the Trail Hospital Tellipalai, and he's also a palliative care physician in Jaffna. This is none other than Dr. K. Gowshigan is going to give a presentation. It's a case presentation. You can start.
Thank you very much for the introduction. Good evening, everyone. Today I'm going to talk about two of my case discussions that I want to share with you all. This is the background of palliative care in Jaffna district. Although the palliative care is an integrated part of medicine, but before 2018 there has been no efficient initiative to take beyond the institutional level in Jaffna. So with the onerous involvement of IMHO and Two World Cancer Collaboration and other NGO like KN, and with the support of oncologists in Tellipalai Teaching Hospital Jaffna, we step into the fields of Jaffna. Since 2019 we have started our home care, and since then we have treated almost 300 patients until now. And with the, as we all know that increasing trend in cancer prevalence globally, and Jaffna is not exception, and lack of public awareness and social stigma and poverty has only resulted in late diagnosis and the treatment. Almost 40% of our patients, when they are diagnosed the initial stage of the disease, unfortunately they fall into the stage 4 disease, which is metastatic disease. So in those case scenarios, the palliative care is inevitable, and with the help of clinical oncologists, medical officers in oncology, and the nursing staff who are working in oncological department, are the core providers of the palliative care in Jaffna Peninsula. So I want to elaborate this, why we need that palliative care in Jaffna, especially in all the world, that even Jaffna also needed the palliative care. Why is it needed? So to elaborate that, I want to share some of my interesting cases. So at the end of the case presentation, you might understand why we need palliative care. So this is my case number 1 that I'm going to discuss here. That 16 years old female patient. I want to just give the brief social economic background of this patient. They are from the poor social economical background, and internally displaced due to the war, and recently relocated near to that our hospital. It's exactly 2 to 3 kilometers within our radius, and they are family of 6 with father, mother, and 3 other siblings. And she is the one that most bright child in this family, and the parents had a very much hope on her, and she also had a very knowledgeable person, and she studied at the time of the diagnosis. She's on grade 10, and she was investigated for the leg pain for 3 months, and that all the investigation lead to that she's having one type of bone cancer, which is Ewing sarcoma, and the stage was initially the stage 2 disease, and it is a curative intention, so that they have started with a treatment which is a curable disease. So during the treatment, the patient and the family is very cooperative, and they had a hope for the cure and never missed the chemotherapy. But almost after 9 months of heavy treatment with the chemotherapy, and that unfortunately the disease had taken an ugly turn, and that after 9 months he was present with the intractable cough for 2 weeks, and we have investigated for that and found out that she has a bilateral lung metastasis. So initially that we had that we treated for the radical intention, then unfortunately changed to the palliation. So since that, we all can expect that they had a very much hope for the cure and for bright future, that all shattered due to that disease progression. And family has a lot of problem that which we encountered, that while talking with them that one day I talked with the family and that sister was there at hospital and she was that patient was admitted to our ward due to that shortness of breath and sister was there and at that time patient was very ill and we also thought that the patient might die in that hospital admission. But while I talked with the family members, that sister told she has a suicidal thought that she may jump out of the window. It is in the second floor, and the parents also told that they bought some pesticide that they are keeping in the home, and if something happens to her, that they are all going to die. It's mass suicide, like. Then it's very disturbing to know that someone going to commit the suicide. So it is very, very preventable. And at the moment, I talk with our oncologist and we arrange the multiple counseling, and we also seek the help of our consultant psychiatrist who is attached to this Tellipalai based hospital. So with a multiple counseling session and this one, we take them out of that suicidal thought. But the child is, we can expect that she is a very fearful and more disease-oriented child with a multiple complaints. That even the problem that we had with during the last days, that there are multiple hospital admissions, and most of the time they end up in the emergency treatment unit due to the shortness of breath and cough and other multiple complaints. So at that point, we made a clear point that we need to talk with the family discussion and we need to explain everything, what's going to happen. So with that multiple sessions we had with the family members, we are able to stop that frequent hospital admissions. So that one. And what are the positive impacts has that the palliative care has in this scenario is with child, that we improve that so much in symptom improvement with for the pain management with the opioids, and for the shortness of breath and cough and everything we are able to control it, and multiple that counseling to improve the mental status. And also to the family we provide the counseling to our consultant psychiatrist himself. He went to the home and did the counseling, and also as well as we provide some financial support. So this is how we comfort that patient at their final stage and the family members. So to provide that the bed at home, that we gave the one of cardiac beds, we got it as a donation from one of the patient donation, and we also gave them some oxygen supplies and nutritional support. So with this, we are able to stop them to visit frequently and ended up in the ETU, and we also explain the disease condition and the disease progression, what's going to happen. So at the end of the time, they are able to accept the things that's going to happen. So after that, the patient also passed away peacefully at her home.
Dr.
And this is the second.
Dr. Gowshigan, sorry to interrupt. I would like to play a video before you move to the next patient, about particularly this patient. If you could stop sharing, that, sure. Come back to you. So I visited this patient's family after she passed away, after 4 months, and spent a morning with them. It was very, eye-opening for me, very educational thing. And I also did a video with their explicit consent, and it was so amazing. And we use this video only for educational purpose. So I'm going to play the video it's a very short video. I'm going to do that, okay?
ஒரு கட்டில் ஹாஸ்பிட்டலால IMH கனடா கட்டில் தந்திருக்கேன். அதாவது புதுவுல புண்போடாத அளவுக்கு ஏர் கண்டிஷன் மெட்ரஸ் தந்திருக்கேன். அதனால தங்கச்சி வீட்டை ஓரளவுக்கு உடம்புல புண்பெறாமல் வேதனை இருந்ததுதான் புண்பெறாமல் அப்படி குறைவா இருந்தவா ஒன்றை விட்ட ஒரு நாளைக்கு வந்து ஒன்றை விட்ட ஒரு நாளைக்கு வந்து வீட்டை கண்டிச்சு பார்க்கணும். இன்ஜெக்ஷன் மருந்து பிள்ளைய ஹாஸ்பிட்டல்லாம் கட்டாயம் எங்களுக்கு கொண்டு வந்து நாங்கள் இங்க பார்த்து சகலை நாங்கள் பார்ப்போம் என்று சொல்லி நான் செய்தேன்.
அடிக்கடி ஆறுதல் சொல்லி வைக்கணும். பிள்ளைகளை வாழ்ந்துட்டு நம்ம செய்கிறது மனதிடப்படுத்தணும். பிள்ளைகளுக்கு கணக்க முறையில் எங்களுக்கு வீட்டை வார டாக்டர் சொல்லணும், இந்த மாஸ்டர் சொல்லணும், மேடமும் எல்லாருமே எங்களுக்கு நல்ல ஆறுதலா இருந்தது. பொருளாதார கட்டைகள் சேர்ந்தவர்கள் அந்த விஷயங்கள் எங்களுக்கு ஆறுதலா இருந்தது. பிள்ளைய வந்து பார்த்த விஷயத்திலேயே முடித்ததுக்கு அப்புறம் பார்த்த விஷயத்திலேயே மாறுது.
So you can continue, Dr. Gowshigan. You can unmute yourself. Okay, here we go.
This is my case, second case, that this show that what are the stigma that we have in the community level. And this is 65 years old male patient that investigated for 1 month history of throat pain and difficulty in swallowing, and at teaching hospital just now the patient was diagnosed with the oropharyngeal carcinoma, then referred to us. So the initial stage 1 disease, so we started with the chemoradiation, which is a curative intervention, and after 3 months of the treatment, patient got defaulted. The reason for defaultation is like patient, even though they are from the well economical background and those, but patient having the poor family support. And the patient was a retired physics teacher and survived by 5, and she was in the government staff and 2 well-educated children who work under government sector. And family is well settled and good social economic background, and the house was well looked up, upper middle class. So in 3 months, the patient was admitted to the teaching hospital again, and the complaint of large ulcerative tumor on the neck. And on different patient arrived to the Tellipalai hospital, and with the severe pain, smelling, getting growth, and loss of weight and loss of appetite. And they have, as patients can't take any orally, they have established a feeding tube in teaching hospital. So these are the poor family support and the poor complaints in the medical advice led to the failure of follow-up therapy. So what we did is admit the patient and relieve the first foremost our concern is to relieve the pain and the wound care, which is very clearly, and we use the opioids and take an absorbent material to control the odor. Once the feeding tubes introduced, we introduced with adequate nutrition, and we had multiple family discussion with the patient and the family members regarding the progression of the disease and treatment modality and proper hygiene and the wound care. Then we have to follow him in the home care. So after 1 week or 1 or 2 weeks, we went to a home, and this is a nightmare, I would say, because we saw that we were taken through the back door, from the main door, and our patient was on the like a partition box separated from the 4-7. There's no, you can even hit the order by miles away. And room has no ventilation at all, and patient was on floor, and you can see that medical advice were not followed at all. So it's a real disappointment for us, and what we did is we cleaned the patient and the wound dressing, administrated the pain management. Our nursing staff also did the feeding through the feeding tube, at the time, and we expressed our disappointment to the wife, who is the main caregiver to that patient. So we scheduled our next visit to the most earliest possible date within the next time. So unfortunately, the patient had passed away before our second visit. Here the patient suffered in contrary to the case number 1 due to the lack of family support, although the family background was good and educated and well settled. So we achieved good patient care at home level through the palliative care in case number 1 because of the good family support, and the case number 2 that although we gave our maximum effort due to the family negligence, the patient suffered and is passing. So proper family palliative care assessment and the management and awareness to the patient and the family, and the follow-up will ensure the benefit of the patient. So it is vital that the utmost commitment of all of us to the palliative care should continue, so that is the treatment reach its fullness. And there are many other cases which we didn't discuss with different scenarios. And we, as a palliative care team, that ensure we will continue to deliver our utmost service to the field of Jaffna. Thank you everyone.
Thank you very much, Dr. Gowshigan, for that dedicated service and that wonderful presentation. For everyone's information, these two doctors, Dr. Gowshigan and Dr. Madhurahan, are working full-time in a different capacity. Dr. Gowshigan is working as a medical officer at the Tellipalai hospital, and Dr. Madhurahan working in the cardiology department. These services, they go beyond their working hours. After hours, they do these services. Now, we have this gentleman, you know what, as in Canada and the Sri Lanka, in India, the health care is managed by the provinces.